In this episode, Dr. Michael Moront takes us into the high-stakes table of bloodless cardiac surgery.
It's a gamble on the surgeon's part, obviously on the patient's part, but cards face up on the table, and if everyone's willing to accept the risks, then we'll do the best we can for them.
Is the deck stacked against you? Have you been turned away because you're inoperable? Well, that's just another day at the office for Dr. Moront's team.
It used to be a very intense major event, and now it's just, that was the morning case. I've probably operated on over 400 Jehovah's Witnesses, and to my knowledge, I've never lost one in the OR or post-operatively from bleeding or anything like that.
If you think bloodless surgery is too risky, pull up a seat and watch how Dr. Moront explains that he has improved mortality and morbidity in all of his patients by practicing bloodless medicine. Today, I'm so honored and excited to be inviting my friend, Michael Moront. He is the medical director for cardiovascular research from the ProMedica Health System in Toledo, Ohio. Why he's so important to me is because when I took on a bloodless care program and I knew nothing, I remember my first meeting and he was the cardiovascular champion. I don't know if you remember that meeting, Dr. Moront. Do you remember that?
No, I don't. I'm sorry.
Well, I can tell you, I'm sure that event was way more important in my life than yours, because here I knew nothing about what I had taken on. Dr. True really was encouraging me to take this on. I was sitting between Dr. True and Jackie Nussbaum, people that you worked with for a long time. And of course, you were saying goodbye to Jackie. And you looked at me and you said, I want to tell you something. You have large shoes to fill.
Yeah.
Good luck,
true.
right?
Yeah.
I always wondered after I moved on from that position, I wonder if Dr. Moront felt like I filled those shoes.
Yeah, I think you did. I think, you took it, you respectfully made it more you mainstreamed it. That's what I mean. You made it. Jackie was kind of a cottage industry, and she did a fabulous job. Don't misunderstand me, but she was kind of almost a one person show. You brought other coordinators on board and standardized it. I think that was a big deal. So the result of where the program is today, which is a very active program.
May is Bloodless Medicine and Surgery Month. So here on the podcast, we really like to take May and think about where the bloodless medicine niche brought us in medicine. It really has advanced medicine.
Absolutely.
So whether or not you would choose bloodless care, I think the patients need to see the importance of serving that population and what that population has done for us. Because probably some of the advancement in medicine we would have never done had we not had to first figure out how to manage their blood and their wishes not to receive blood. When were you introduced to this population?
During residency in general surgery and cardiac surgery, we would have an occasional Jehovah's Witness patient come through. But as a resident, I had no control over the patient, so to speak. We did the best we could. When I came to Toledo in 1993, my senior partner, who was Dr. Robert Rowitzer, had already had a good working relationship with our bloodless people, specifically the Jehovah's Witnesses in the community. He asked me to, talk to me about doing them. And at the time, myself and the other partner that was here, we all did the witnesses, bloodless care patients. We learned a lot over time. Very clearly, we became quite refined at it. And then, and everyone, the anxiety in the room was high. The attention to specific details was high. Every time we had a bloodless pair patient come into the room, I'd be calling the anesthesiologist and the nurse and saying, limit the fluid, don't give a lot of fluid, be careful with the IVs, make sure the art line is perfect, that kind of thing. Then as we, would start the surgery where we might leave a small little area of bleeding, we would take care of it immediately and effectively. the expression in cardiac surgery is dry in, dry out. And that there's a lot to be said for that. As I got going further and further along, it became, second nature. And more importantly, what was our intensive focus in bloodless care became our norm in patients who weren't requesting or demanding bloodless care. There's a lot to be said for that. And I think many institutions don't have that mindset. About 2010, we became involved because we had a number of patients. We found we were having patients had to go back to the operating room for bleeding when they looked good. We would take them back to the operating room and we wouldn't find anything bleeding. It was coagulopathy that was basically undiagnosed. We worked with a company to use thromboelastography testing. That made a tremendous impact on our practice. In 10 years, it took our reoperation rate from 6.5% down to 2.3%. So dramatic reductions there. And also we performed studies which demonstrated shorter length of stays, dramatic reductions in transfusions, and perhaps most importantly, lower 6-month mortality. And it's a consequence of the transfusions the patients did not receive. The viscoelastic testing allowed us to, rather than a shotgun approach of giving platelets, plasma, and cryo, and potentially a little bit more protamine, our most common intervention now with viscoelastic testing is another 100 milligrams of protamine. Simple and
Wow.
easy.
Yeah.
Also with the viscoelastic testing, it'll tell us we don't need any plasma, we don't need any cryo, we just need platelets, or we just need
Mhm.
cryo, what have you. So again,
Right.
it's a rifle shot appointment as opposed to a shotgun approach. Over the course of time, this team has matured to it, so it's everyday care.
Why were you so open to the idea of being that person when a lot of other surgeons don't like having their hands tied?
A lot of patients who are very ill come to you and they really don't have a lot of other options. And we're all in the business of trying to help people who need to be helped or want to be helped. It's always very easy to say no, and it becomes stressful position to take on patients where you've got your hands tied behind your back a little bit. Not only with bloodless care, but even across the spectrum of cardiac surgical patients. I kind of took on what I would consider to be the impossible mission cases. All cardiac surgeons think they do it, and yeah, I'm sure they do. But I mean, I did it as a routine. I was doing 2 and 3 and 4 a week, and so doing bloodless care patients was just another file in the impossible mission folder, so to speak. I've always felt that patients who have high risk, um, the cardiologists routinely know it, the internists know it, the families, it's important for me to relate to them exactly what they have and the patients what they have and the risks that go along with it. And if they're willing to accept those risks, then I'll do the best I can for them. And it's served me pretty well. I've probably operated on over 400 Jehovah's Witnesses, and to my knowledge, I've never lost one in the OR or post-operatively from bleeding or anything like that.
So your outcomes were similar?
Oh yeah, very similar. You just can't take Jehovah's Witnesses who are anemic or thrombocytopenic or anticoagulated directly to the operating room. You have to get them tuned up, and that takes some time. And actually, over the course of the last 15 years or so, 20 years, we've learned to use epogen very well to boost the red cells. And we've used steroids sometimes to boost their platelet counts. The steroids work sometimes, but we also started using other medicines, platelet agonists, to improve their platelet counts. We recently submitted an abstract where we took 12 Jehovah's Witness patients who, in my opinion, were inoperable because their platelet counts were well less than 100,000 and required major cardiac surgery, not just a coronary bypass operation, valve coronary, aortic arch surgery, aortic root surgery. We were able to give them this medicine, and over the course of time, that medicine basically normalized their platelet counts, and they all did fine. No bleeding episodes, no deaths, anything like that.
I remember when I was there at the bedside of a patient where it seemed as though they were inoperable and you were trying to get them tuned up and their platelet count was just not rising. Dr. Ostra, who's the medical director, and you and myself in the room with this patient, I think we had tried IVIG, we had tried
Hmm.
steroids, and you were like, "What do you think of this end plate?" It was the first time I had heard of end plate. That we brought it on and that the person went into surgery not long after that. So you started out 30 some years ago. Were you tuning up patients at that time, or is that a skill that you kind of grew into?
I definitely grew into it. The platelet agonist started, I think, in 2019, 2018, 2019. Uh, Epogen has been around for a long time. I think that you just have to be smart about it. And like I say, I kind of the opinion, you lay the cards face up on the table, and if they've got to go urgently or emergently, then you do the best you can. And you got to be diligent about not only hemostasis in the operating room, but then if their red cell count is low, giving them massive doses of Epogen post-operatively immediately and things like that. We also have a number of other technologies that we've used, and we've changed our perfusion circuits such that the hemodilution that occurs, that used to occur, no longer does. We go on with a dry venous line. We do what's called retrograde arterial wrapping, called retrograde arterial hemodilution. And there's a number of other technologies we use to minimize the hemodilution, also taking blood off and keeping it in circuit with the patient. So we have pretty significant whole blood transfusions to give the patient following surgery after protamine's been administered. So again, there's a number of techniques that we've developed, used, and like I said, it was used every day in my operating room until I retired.
Yeah.
Every day, just commonplace. Yeah.
There were urgent cases, had to be going into surgery in a short period of time. You didn't have the time that you would like, but you would say, bring them in on Friday. We're going to dose them hard with EPO and we're going into surgery on Monday. Even that short amount of time, what benefits did you see from doing that short condensed tune up?
A lot of times if we could, we would diurese the patients, which would hemoconcentrate them to some degree. We would give them the Epogen, which probably did not impact them the day of surgery, but postoperatively by day 3 or 4, instead of hemoglobin levels staying low, they would start to rise. Again, I think that improved their overall survival. It's a gamble on the surgeon's part, obviously on the patient's part. Again, cards face up on the table, and if everyone's willing to accept the risks, then we'll do the best we can for them. Respectfully, to God's helping too.
Yes, absolutely. A wing and a prayer sometimes, right? Or
Yeah,
a scalpel and a prayer.
exactly.
Did you turn away more complex cases? Were there ever cases that you were like too complex? Because you said that you never lost one and cardiac surgery can be dicey.
Yeah. You know, I, I'm sure I have. I cannot recall specifically ever doing that. Having a complex surgery to perform is one thing with significant risk. Adding the Jehovah's Witness or bloodless care to it is another layer of risk. The thing that's most important for me when I evaluated high risk patients was, can I get them through it and will I then prove them with the surgery? I mean, if you're just taking a patient that's got, say, heart failure, and when you finish, they're still going to have heart failure. They may not be quite as short of breath, but if you don't make a dramatic impact on that patient, then you're not helping them. And you're putting them at risk. And again, bloodless care adds another layer of risk. So I think that I first have to be convinced that I can help the patient. Um, and then there's some events that come up acutely that you do specifically, like endocarditis, patients with heart valve infections and things like that. Those patients tend to bleed anyway because of sepsis but I mean, you gotta go in and do what you can, do the best you can. And, because respectfully, a lot of these folks will go on to die if left untreated. A lot of the bigger university programs, I've taken patients from the Cleveland Clinic, from the University of Michigan, because they refuse to perform or consider bloodless care, and we've done them successfully. Some of them are complicated, some of them are not. Some of them are just coronary surgeries, but having this isn't a criticism, but having resident staff that may not be as meticulous about their surgical techniques as I was or my partners were is just the truth. They just don't know it
You're
yet.
right.
They're learning.
Well, and there's value in knowing what you don't do well and giving them to the hands that someone that you know does it well.
In cardiac surgery, blood loss is measured in liters.
Mhm.
But,
Wow.
200 here, 100 there, 100 there, 100 there, and before you know it, you're talking serious blood loss. So I think I learned to be meticulous from the start and also address problems as they arose immediately. Unless other issues were more paramount, routinely, if there was any type of bleeding, we would just address it immediately and take care of it. With the heart
Mhm.
lung machine, we have the ability to aspirate blood from the field and return it to the patient. But on the other hand, if it happens a lot, you're stripping clotting factors and platelets from that patient. And we don't need any help doing that.
So the heart lung machine has the ability to take the blood as you're losing it, and then there's the cell saver.
If they're using cardiopulmonary bypass, say for a heart or a lung transplant, and I think even at times they're using some degree of cardiopulmonary bypass for livers. I don't do that, but you have the advantage of using the heart lung machine to aspirate blood from the field.
How important is your perfusionist and your anesthesiologist in managing a bloodless care patient or great patient blood management in general?
Critical, absolutely critical. I can remember back 30 years ago. I remember we had an anesthesiologist who I hadn't worked with much, and we were doing a case, and it wasn't a bloodless care case, but I turned around and I look up and there's like 6 IV bags, 6 liter IV bags that are empty. And I said, and the crit's down to like 20 on the patient. And it's like, did you really get 6 liters of fluid here? Yeah, I guess we did.
Mhm. Yeah.
I didn't use him a whole lot more as an anesthesiologist, but we have been absolutely blessed at Toledo Hospital to have a cadre of superb anesthesiologists who are communicative and very interactive during the operating room. Probably even more blessed we are to have the perfusion group that we have. We've had a very, very stable perfusion group in the 32 years that I worked in the operating room. Kevin Fleming very much is the leader of that group now. And he's innovative, he's easy to work with, he's thoughtful, and he has a number of very, very thoughtful people working with him. Let me just say that if myself or one of my family members had to go to Toledo Hospital for cardiac surgery, I would not worry who the perfusionist was at all. We have no qualms about it. They're innovative. They stay on top of the literature. They have done a number of things to change our circuit to make it more efficient, less hemodilution, and things of that nature. So I think we've been very fortunate. You know, a lot of places the perfusionists are just they're employees of a company. They're not even based in the hospital, and they want to do a good job. I'm certain of that, but they have no ownership of the program. Our perfusionists do, and that's I think a huge difference.
I think most people, lay public, don't even know what the perfusionist does or what they do. They probably know that the anesthesiologist, they meet them in pre-op and they at least know that they're going to put them to sleep. Tell us a little bit about what a perfusionist is doing for them while they're asleep.
Patient is asleep, and again, an integral part of that is that anesthesia does not flood the patient with fluid. They may need to start some blood pressure medications, specifically if the patient is struggling with their blood pressure. Sometimes it is fluid that's required. Sometimes they come to the operating room anemic, and it's not a bloodless care patient, so you potentially even have to give them some blood. The first thing that we do with our perfusionists, however, is before the patient even goes to sleep, they perform thromboelastic testing. The device we use is from Hemonetics. It's called the TAG device. It basically gives us a baseline of where that patient's coagulation status is before we give heparin.
So the risk of bleeding.
Right. So it assesses the risk of bleeding preoperatively. So we got a kind of a little bit of an insight to say, God, the platelet function, or we know what the platelet count is, but we don't know how well the platelets function. You can have a lot of platelets, but if they don't work because of medications or what other things is another issue. We open the chest and we prepare the various conduits, whether it's the mammary artery or the veins from the leg. Once we're ready to go on the heart-lung machine, we give a medicine called heparin, which basically causes the patient to not clot. When we go on the heart-lung machine, we're going to run the patient's blood through plastic tubing and through filters, which are going to oxygenate the blood and remove carbon dioxide. If they're not heparinized, they would clot, and that would be a bad thing. Once the heparin is in and we know that we've fully anticoagulated the patient, and that if you took a tube of that patient's blood and set it on the shelf, you come back a millennia later and it's not going to be clotted if it's working appropriately. We're the only people in the world that, open someone's chest and heparinize them so that they don't clot at all, and work on their heart, stop their heart. Hopefully it's going to start, and then reverse the heparin medicine and hope they're going to clot. So once the heparin is in and what we call the activated clotting time is adequate, we put cannulas into the ascending aorta routinely and then into the right atrium. The blood from the right atrium is drained back to the heart-lung machine where it's oxygenated, CO2 is removed. It can be heated or cooled. For the most part, we stay relatively warm at 36 degrees. We can add medications, blood products, anesthetic gases, fluid to the heart-lung machine because the patient and the circuit are one. And then it's returned to the patient via what we call the arterial line, which is usually the ascending aorta, to perfuse the patient and the body. Once we're stable and on the heart-lung machine, we routinely put a cross clamp below where the aortic cannula is on the ascending aorta. And what that does is it stops the blood flow to the heart. We have another small cannula, which we introduce medicine into the aorta, and then subsequently it goes into the coronary arteries to arrest the heart. We call that medicine cardioplegia. So we arrest the heart, and we can give this medicine somewhere between every 20 minutes and every hour. At that time is when we work on the heart, whether if we're doing a coronary bypass operations, we figure out how many bypasses they need beforehand, and we know we've got the bypasses. If you think of my finger as the coronary artery and the knuckle is the obstruction, we plug in a conduit or a tube beyond the point of obstruction in the coronary artery, and then that goes to a blood source, whether it's the aorta or what have you, and it basically bypasses the obstruction and brings new blood flow to the heart beyond the obstruction. That's what coronary bypass surgery is. When we're finished doing all this, we take the cross clamp off and we let the blood from the heart-lung machine perfuse the heart, which washes the cardioplegia out, and the heart routinely wakes up. Sometimes it wakes up in ventricular fibrillation. We give it a small shock, and they go back into normal rhythm. Then once the heart's adequately working well and the patient is warm and the hemodynamics look reasonable, we wean them from the heart-lung machine, remove the cannulas, and then we reverse the medicine, which the heparin medicine with another medicine called protamine, and go from there. And then dry up and close them up.
The role of the perfusionist is basically perfusing your body. It is acting as your heart and your lungs while that is arrested.
Right. And even when the heart's beating, sometimes, the patient's heart may not be ready. There could be bleeding that needs to be addressed. By having the patient on the heart-lung machine and coordinating our care and efforts with the perfusionists about lowering the pump flows or increasing the pump flows or what have you, it's not even a team effort as much as it is a ballet. It is a partnership. And like I said, we're very, very fortunate having worked with these folks for some of them 25, 30 years. They know me and I know them. We're very fortunate to have the crew that we have. But they maintain the patient while we're working on doing the bypasses or replacing a valve or what have you. It's a critical operation, and it takes a couple extra years of training, and then it takes years of experience to do it well.
Wow. Well, shout out to all our perfusionists.
Right.
You're very under-recognized for sure.
Yes.
What was your experience like with the bloodless care population?
I was always remarkably impressed by how grateful they were even to talk to me.
Hmm.
Not taking them to the operating room, but just even to talk to me, and I would consider performing their surgeries with their religious beliefs in mind and honoring those beliefs. Again, very, very grateful with, as I said before, you lay the cards face up on the table. The witnesses my bloodless care patients had no problems whatsoever, you know. So I had to be very, very direct with them. And every single witness I ever operated on, I'd ask them one time, one question. In the event of fatal or catastrophic bleeding, do you refuse all primary blood products? And they all said, yes, I do. And with family members or other nurses involved. So it's, you need a witness. And I would very carefully document that in the chart. That was the deal. That was the game plan. And that's where we were.
Yeah. How do you think that benefited your organization over time? ProMedica really was an early adopter of bloodless medicine. I think they were a very early adopter of viscoelastic testing. I just assumed when I met you and Kevin Fleming that all hospital organizations had viscoelastic testing. That was not true. And you guys were well experienced and all had done research for years in it by the time I came on in around 2017.
Well, I think I inherited a great relationship from my senior partner, Dr. Raucher. He had a great working relationship with Dr. True and with the Bloodless Care liaison team, Jehovah's Witness liaison team. So I think the stage was set, so to speak. The table was set to help bring it up and take it to another level over time wasn't particularly difficult. I have gotten patients from Chicago. I've gotten them from Pennsylvania. I would consider us a regional referral center, never mind local regional. For us, 50 miles out, no other institution other than potentially the Cleveland Clinic or Ann Arbor will operate on them. But so we capture that 100-mile radius completely, I think. I don't know that for a fact, but that would be my guesstimate. And it doesn't just happen in cardiac surgery. It happens in GYN oncology, general surgery, neurosurgery, across the board. I can't tell you or name, you probably know much better than I do, the physicians that are willing to have the same brand in those different entities, who's willing to accept those challenges. But I think it's been a good thing for the hospital, and I think that with some of the research we have going on now, with in this new position that I'm in, we're going to raise the flag even higher.
That is great news. I can't wait to follow it. I think we started out and we did pre optimization of bloodless care patients because we knew our hands were tied and we were not going to be able to use blood. The organization has moved very great into also pre optimizing everyone.
Yes,
Let's bring everyone in.
right, right.
Um, and protocols in place during a hospital admission where we were addressing the hemoglobin drop. So now we moved from doing that for a niche population.
Yes, absolutely. I completely agree. Again, red cells are the easier ones to attain. I think the thing that's most important there is when you have a patient that's potentially anemic, that from the start, if you recognize they're going to have to go to the operating room, you have to start them down that road. You just can't keep, waddling down the
Yeah.
road and haphazardly keep drawing big tubes of blood 3 times a day
Hmm. Hmm.
for them. And if they're respectfully GI bleeding or vaginally bleeding or what have you, that's got to be addressed, period. And I think people are more in tune with that now. It's just good
Yeah.
care. We have the
Yeah.
staff and the backup and the facilities to do it and the right attitude.
You leaving, you retiring, that leaves a big hole. Someone's got large shoes to fill. Who's taking that on so that that the standard of care doesn't get dropped?
We have currently 2 surgeons. One of them was one of my partners, Dr. Christopher Reardon, who was performing bloodless care surgery when I was still working. He didn't do as many cases as I did, but he did do some, and he's done them very successfully. We recently have hired a young man by the name of Dr. Robert Rother, who's willing to perform bloodless care patients. It is my specific intent to help him learn how to preoperatively optimize these patients to the best of our abilities so that the risks are mitigated to the best
Mhm.
degree possible. I think he's willing to do that, but he's still kind of figuring out where the cafeteria and the bathrooms are. He's only been here about a week, but he's going to do great. I think he's going to do great.
So your new role, you're leading research for the organization in cardiovascular. Tell me a little bit about your role and then also the work that you're doing that's going to advance patient blood management even more.
As the medical director of cardiovascular research, my have umbrella coverage to promote and bring new research and hopefully see it through to completion and publication or financial aspects within the organization for cardiac surgery, cardiology, vascular surgery, cardiac anesthesia, and perfusion. Throughout my years at ProMedica, I was able to do a number of fairly high-ended studies in cardiac surgery specifically And over the course of decades, I acquired a lot of different interactions with commercial providers. These people know me, I know them. They know that can come forward with admitting patients and enrolling patients. So I do that now as for across the board. Cardiac anesthesia is integrally involved in so much of our cardiac surgery work, and even now with our structural heart work and EP work, that was an easy one. Perfusion's always been part of it. So it's an easy marriage to put that whole group under one person's kind of purview. Cardiology has had a dramatic uptick in research in the last year or so, specifically in the structural heart realm, and also with a number of the new medications that have been involved specifically for amyloidosis and for hypertrophic cardiomyopathy. We've got some superb people here now in the structural team, specifically Dr. Stephanie Yonis, Dr. Kasi Ramanathan, Dr. George Hanna, and we just literally acquired a new study for them to work on for specifically with patients with aortic valve insufficiency. Aortic valve insufficiency is not something that the routine transcatheter valves can treat, but this new valve does. It's called the Jenna valve. And we also have other tricuspid and mitral valve solutions, which are percutaneous options, and it's all done in conjunction with the surgeons. The development of the structural heart team, which has happened over the last 12 or 14 years, has taken down a lot of the silos. There was cardiac surgery, there was cardiology, and now we've kind of opened it up and made it one. What's ever best for the patient, and that's the truth. And structural heart is in a dramatic evolution of new technology, and some of it's very, very good. There are new medications out there which are really helpful for patients with amyloidosis. My own brother-in-law has cardiac amyloidosis and was in heart failure. He's been being treated with these medications, and the other option he had was to get a heart transplant. I don't think that's going to be necessary now. The vascular surgeons are working on a number of different technologies. Some of the stuff that we work with them is what's the best medicine to treat patients who've undergone stents or lower extremity bypass or carotid bypass or stenting, so that one, their stents stay patent, and two, they don't bleed.
Mm.
The switch off there. We are working with different companies to potentially change how we transfuse patients, called lyophilized or concentrated fibrinogen, that now we're now evaluating for routine use in the operating room. And there's a lot of advantages to those lyophilized products. They're very rapidly administered. They have no volume requirement of any significance. They have no infectious component to them. And when you're in the operating room time comes somewhere between $100 to $200 a minute. So by the time you type and cross somebody, send it to blood bank, if they need to, they have to thaw, cryoprecipitate, type and cross it, get it back up to the operating room. Even in a perfect system, it's a 45-minute to an hour setup time and turnaround time where the lyophilized fibrinogen can be pulled off the shelf in 5 to 10 minutes and administered. 30 minutes is between $3,000 and $6,000 worth of OR time. Never mind the fact that they're still bleeding and you have to give other blood products to maintain
Yeah.
their hemoglobin and things like that. So financially, it's going to be very, very well worth it as we go down this road. You know, a lot of other follow up that we've done over the years. So I'm very, very pleased with what we got going here.
What would you like to tell the general public and or colleagues about your experience in bloodless medicine, patient blood management, or otherwise?
Without a doubt, caring for the bloodless care patients and having to think about it and focus during not only during surgery but to preoperative evaluation and tune up of these patients, and then postoperatively being very cognizant and very watchful about how everything gets done. And again, we've done so many of them and we've got a lot of experience with it. It's almost second nature now. It's not, it used to be a very intense major event, and now it's just, that was the morning case. And I don't mean to make light of it, but on the other hand, that's really where it's gone to. I think that it has absolutely made me a better surgeon. It's made me more thoughtful, and as I step into this new role, I think of ways to expand what I've learned clinically and reach into new areas that I respectfully didn't have time to explore when I was still working 80, 90 hours a week as an actively practicing cardiac surgeon. And I think we're going to get some good stuff done in the next year. I really do. I'm very confident we will. pushing back the frontiers of science.
If you're a patient in Southeast Michigan or Northwest Ohio, one thing I can say is you're in really good hands. Thank you so much, Dr. Moront, for letting me go down memory lane. You taught me so much. Kevin Fleming, Dr. True, these are mentors that I will not forget. And I know that Bloodless Care patient blood management team are dedicated and they are doing great work. And so just thanks so much for the conversation today.
Thank you very much for having me. And again, the ability to contact me is through you and through your podcast. I'm happy to entertain any questions or what have you about this.